Oh gosh, microphone's over here. Hey everybody, good afternoon. It is 4 o'clock in the Rocky Mountains, which means there is only one place that you should be, and you are right here with me. Good afternoon or evening, 6 o'clock to those of you on the East Coast and 3 on the West. It's Fertility with Fink and Friends. My name is Dr. Randy Fink, and I am the clinical director of IVF services here at CNY Fertility in Colorado. And it is wonderful to be with you here this evening, as we are every Tuesday afternoon. So let's see, we've got a couple of different Instagram feeds. We've got my Instagram here, we've got CNY's Instagram here, and we've got LinkedIn, Facebook, and YouTube right over here. I think I did that right. Yeah, I think so. Good deal. How is your Tuesday? How was your weekend? We got some snow here in Colorado, and it was always 10 tons of fun. Still trying to fight off this cough here. Those of you who get chronic coughs know what that's like. It may hang around for another 3 or 4 months after getting an upper respiratory viral infection. So that is absolutely no fun. No fun to have to deal with there. But happy Valentine's Day, by the way. What do you think of Valentine's Day? I have not always been a fan, just because Hallmark and those folks seem to make a fortune off of us, and there's this expectation that we are to be buying cards and all those sorts of things. But it's a special time because I remember, even to this day, my beautiful mother in Mobile, Alabama, who is probably watching right now, haven't seen the names yet there, would always get me, mom and dad would always get me a little thing of candy and a Valentine's. Never, ever, ever forgot in all my years. So that's what makes it special, and I hope it will otherwise be special for you. Let's see who we got going on here today. So first to join on the CNY side, Jackie Drew. Welcome. Good afternoon. We've got Midwest Roots and B Voyager, Shanty Dib, Barbara Brown, Devi Capershed, if I'm not saying it right, but hi, how are you? Just ask Lena Forever, Deha Rick Fraser, Danielle is here. Hi to you. Miss Y Gracie, Nay Love, Skittles 8799 is here, as well as Mags Cambor. I'm trying to read it so fast. I'm forgive me for mispronouncing the names. We've got a few people on the Facebook side there. Good afternoon to you, Jade Snow, Scott Wormwood. Scott looks like Scott and Mel Wormwood. Glad to see you there. And here on my Instagram side, a very special hello to Ryan from our anesthesia department. Coming at you, Fink in the house. That is right. Brandis, our nurse practitioner extraordinaire here in Colorado, is on with us today, as is Amber Vince in Kentucky, who is enjoying a beautiful pregnancy. Hope you are feeling well, Miss Amber. Our favorite cowgirl is here, as well as Lex Blackwell. Hello, Zaneta in Miami. Rezik Blue in Las Vegas. You guys had a busy weekend. I just talked to a patient in Las Vegas earlier, and she said that, gosh, it has been kind of a crazy, the traffic and everything else, what with the Super Bowl. I hope you were all happy with the Super Bowl results. I have nothing to say because, whatever it is going to be wrong. So Super Bowl was fun to watch. Bree Bales is here, as is Layla and Ms. Stock 87. Well, let's see if we can get to some questions here and hopefully settle some minds. By the way, Ryan, we miss you. We miss your scrubs. Ryan will be back next week. We have Kelly in-house for anesthesia. And Amber Vince is telling me 16 weeks on Thursday. Thanks to me, Brandis, and everybody here in Colorado. And we are so happy for you, Miss Amber. Okay, Skittles, what do you recommend doing leading up to an FET? I'm transferring in April in Sarasota. So for a frozen embryo transfer, really the most important feature is going to be, in my opinion, leading up to, there is an evidence-based list of supplements, right? And that includes a prenatal vitamin, vitamin D, vitamin E, CoQ10, and L-arginine. These are the things that are associated with embryo transfer success, with improving the odds of an embryo transfer. I am a big believer in a modified natural frozen embryo transfer cycle as opposed to a medicated cycle, but they are both fine. Really, the question is, where are you getting your estrogen and your progesterone from? And that's what means the difference between a natural versus a medicated cycle. But as far as leading up to it, Skittles, I think the best thing that you can do is just hop on those supplements, because that's really an evidence-based solution that has been shown to make a difference. Mags is saying, or Mag, I'm so sorry I mispronounced it. Have you seen IUI or IVF be successful in someone with higher stage endometriosis? The answer is yes, absolutely. So, the thing about endometriosis, and I've talked about this before, I can operate on somebody. Let's say maybe I'm going to do a tubal ligation in someone who might have, 4 kids. She's in her 40s and she doesn't want to have to worry about contraception anymore. So we're doing permanent sterilization. And we put a scope in through the belly button, go to tie the tubes, and find that she is absolutely loaded with endometriosis, but yet she has not a symptom at all, nor did she have any difficulty getting pregnant with that endometriosis. So, can that happen? Absolutely, it can happen. Whereas there are other people who may end up getting a laparoscopy for fertility reasons, and only to find that, well, there is a trace of endometriosis on the inside, but we don't know if that's the cause of the fertility problems or not. Maybe it is, but maybe it's not. So yes, IVF, it can be very successful with endometriosis. It is one of the treatments of choice, because we know that when, so what endometriosis does, it really does 2 things to stand in the way of fertility. Well, in one sense, it can cause some scarring and it can cause some blockage and some problems, kind of mechanical problems on the inside. And that's always one possibility. But, as far as an egg retrieval goes, if there is endometriosis in the ovaries, endometriosis can affect egg quality. So, it can affect actually ovarian reserve. Forgive me, ovarian reserve. But really, the issue comes as it pertains to doing an embryo transfer, because endometriosis changes the way the brain is talking to the uterus. And how does it do that? It can create an inflammation in the lining of the uterus, and that's something that we are actually able to test for with a test that is known as Receptiva, that's looking for a marker that's called BCL6. And BCL6 is an inflammatory marker that is highly associated with endometriosis. So if you've got endometriosis and you're expressing this BCL6 marker, that's the way endometriosis is going to try to prevent you from getting pregnant, because what it's actually doing is that it will take what should otherwise be a very effective treatment, like let's say you even have a tested normal embryo. Well, if we put it on the inside, we know that that embryo should be giving you a 65% probability of being able to get pregnant. Endometriosis turns that down to less than 10% unless we treat it. So in your situation there, knowing that you've got higher stage endometriosis, before doing an embryo transfer, I would 100% want you to do medical suppression. And that's using either Lupron, Orilissa, or Myfembree to turn down the volume knob on the endometriosis on the inside and to shut off that production of the BCL6 marker, which can interfere with the pregnancy. So yes, indeed, endometriosis is not something that should stop you from being able to get pregnant. Hello, Macro Mama. I like that. Macro Mama, Shabnam TKS, good afternoon. Faith Waring, hey, good to see you. If I have one estrogen leaking cyst, how likely is it to have more again? Well, cysts are something that we look at the beginning of your cycle. So, one of the reasons that we do the baseline in the IVF cycle is so that we can see what's going on in the ovaries and check those baseline fertility levels. Um, Almost everybody will have some evidence of a hormone secreting cyst at the beginning of the cycle at some point. Inevitably, it happens when we're trying to do IVF, so we're watching for it. So it just kind of shows up. It's pretty straightforward to treat that. So usually what we do is put you on some suppression, put you on basically some birth control for a little while, and it usually allows that cyst to go away. If you've had it once, will you have it again? Pretty much it happens to every woman at some point. It just happens to be that, in this fertility business, we're looking for you at the beginning of every cycle. So we kind of see where it is. So will it come back? Yeah, it probably will. Let's see. Hey to Sam. Good afternoon. Glad to see you here with us as well. Ruzik Blue in Las Vegas says, can you talk about HLA and V158? I have a positive V158, which I hear could mean my body is rejecting any embryos. So what you're talking about there are some of the autoimmune markers that can that can affect the way an embryo will implant, right? So good for you for testing for those. The truth of the matter is that so let's actually just talk about that. At CNY, we generally include an immune protocol for just about everyone who is either doing an egg retrieval, doing an embryo transfer, or even folks who are doing insemination, doing an IUI. And why do we do that? Because the immune system always has something to do with how we get pregnant or not. The real fact is that we don't always have the ability to be able to test for a lot of these markers that can be associated with immune problems. So we cover those bases. There's a type of doctor that's called a reproductive immunologist. And the reproductive immunologist is a very expensive doctor to go see. First of all, they have a very long waiting list. When you get in, it's usually all cash. It's typically not something that's covered by insurance. And they do a lot of very expensive testing, including things like the V158 and the HLA testing to try to see if there is something in the immune system that may be preventing you from getting pregnant. They come up with a list of recommendations. To be honest with you, very rarely, in fact, I can't even think of a time that I have seen recommendations come out of a reproductive immunologist that are far different from what we might recommend as part of our immune protocols anyway. So between intralipid, which is going to be treating things like that's the lipid infusion, the fat infusion that kind of looks like a milkshake that you do before an embryo transfer. That treats something called natural killer cells, which are difficult to assay accurately. The HLA issues can be handled by things like prednisone, which is a steroid that decreases the immune response. We do things like Lovenox, which is a blood thinner, and baby aspirin in order to try to diminish some of the things that can cause clotting in the small blood vessels that supply both the uterus and the placenta. These things are really part of what we do on a daily basis with just about everybody. So we don't necessarily encourage all the testing because a lot of times it gives us results that don't remarkably differ, Ruzik, from how we might otherwise treat you. So what does that mean for you? Well, now that we know that you have these things, we're going to make sure that those bases are covered with the immune protocol. Let's see. Galaviz. I don't know. Sorry if I'm mispronouncing. Success rate of fully hatched blasts graded a 6. I hear they are more fragile, but also hear they might be stickier. Well, so what you're talking about is embryo grading. And embryo grading is something that we generally encourage people not to pay too terribly much attention to because the grading does not necessarily correlate with the pregnancy outcomes. What do I mean by that? You can have a very highly graded embryo that has multiple complex chromosomal abnormalities when you put it through PGT testing. Or you can have a poorly graded embryo that people say, oh, it's not a good graded embryo. So I just don't feel very confident in it. When that may be the only chromosomally normal embryo in the bunch. So, the goal of embryo grading was originally established so that an embryologist could look at an embryo and characterize some things that they see under the microscope. And based on that characterization, try to determine, well, which embryo is normal and which is not. Unfortunately, it turns out that those things don't correlate really at all. So again, if you've ever done PGT testing with your embryos, you'll see it's not that the best graded embryos are the ones that are most likely to be normal, because once we have a PGT test an embryo and we know that it's normal, that's the one that has our highest chance of success with pregnancy. So that's really kind of what we're looking for. A grade 6 embryo is an embryo that is fully hatched. All right, so just like a hard-boiled egg, or just like an egg, where the little baby chicken is coming out of it, the embryo itself starts to hatch out of the egg. A grade 5 embryo is an embryo that is hatching. All right. Whereas a grade 6 embryo is an embryo that is fully hatched. And really, you're right on both accounts. It's fully hatched, which means it's maturing. It's continuing to try to grow, which suggests, pardon me, even more that it's a normal embryo. It's continuing to try to develop. But yes, they can be more fragile. That's why we take great care with every embryo. There is a particular means by which we do an embryo transfer. It's an acquired skill. It's not something that you just sort of walk into and push it in. So the embryo catheter has to be in just the right spot. We try to do the minimal amount of traumatizing to the surrounding tissue in order to place the embryo inside and give it its highest chance of success. When we sort of squirt the embryo in, it's not just a and it goes. It's sort of a very delicate way where the syringe sort of rolls off the finger. So, there's a technique in it. And so I wouldn't say that we are more likely to injure or damage an embryo that's fully hatched. But again, it's just something that they want to be careful of. But yes, it probably is a little bit stickier because it has developed itself more. Good question there. Hey, let's take a look at the Facebook side. Hello to Lena Psychic Reading. Very interesting. Nice to have you here. I got all kinds of questions on the Facebook side. So, pardon me. Scott and Mel say, good evening from upstate New York. Tomorrow, the wait is finally over and we do our beta. All right. Thanks for all you do and what got us here. God bless. Scott and Mel, all our thoughts are with you, my friends. Yeah, the waiting is the hardest part, isn't it? After you've done a transfer and you're waiting to get that positive beta, but our prayers are with you, our thoughts are with you, and our fingers are crossed. Looks like, Nicole from Palm Bay, good afternoon from Florida. Nice to see you. Jade Snow Klein is here, who has a question. Go right ahead with your question. Hi to Victorious The Victorious and Melissa Judith Rios. Oh, Melissa Rios says, hi to my favorite doctor. Well, tell me who it is and I'll make sure he finds out. So, oh, it's Dr. Fink. Thank you. What levels do you guys look for during a beta HCG test? So really anything that is above a 5 is considered a positive test. We look to see, and we often expect those levels to be, higher than a 6, 7, 8 in the very beginning. When they're very low like that, we get concerned that, well, that may not be a healthy ongoing pregnancy. But really what we're looking for is we look to see the beta doubling in about 48 hours because 2/3 of them will double in 48. And so that's kind of what we're after there. So again, fingers crossed. Jade asks, what would you suggest for a first round cycle for tubal, someone who has had a tubal ligation? So once you've had a tubal, Jade, then the highway is blocked. So sperm and egg can't meet one another. Now, there is always a failure rate associated with a tubal ligation. About 4 out of 1,000 people can still get pregnant despite everything being done correctly in a tubal ligation. It is coincidentally the same failure rate as that associated with an IUD. It's about 4 out of 1,000. So for many people who are not 100% sure that they want permanent sterilization, we'll talk about getting an IUD instead because it's the same failure rate as getting a tubal, but it is pretty much immediately reversible. But once the highway is blocked and sperm and egg cannot meet one another, IVF is really your only option. So how do we dose the medications with IVF? It is principally based upon age, because based on your age, we can determine what we expect or how we expect your ovaries to respond. The secondary factor there is by the AMH blood test, the anti-Mullerian hormone, which is a reflection of your ovarian reserve and really is predictive of how the ovaries are going to respond to stimulation medication. So Jada, I would say IVF is your choice because there really is no other choice after a tubal ligation. Age-based, secondarily AMH-based with the dosing. Now, some people say, well, what about, wait, you said there's no option. What about getting the tubal reversed or getting my tubes untied, as they say? Well, it doesn't always work. It can leave behind some scarring. It's never something that's covered by insurance. And so in general, I would be more of a fan of IVF just because the outcomes, depending on the situation, but in most cases, I would say the outcomes from IVF are going to be superior to the outcomes from getting a tubal reversal. Melissa Lou says, hello, Dr. Fink. Hello, Melissa. 35 in April and coming into our first round of IVF, debating on doing genetic testing, the PGTA. Okay, this is an important question, and I think that it's something I really want everybody to understand. We've talked about this before, and that's what is the benefit of PGT testing, or specifically PGTA, pre-implantation genetic testing for aneuploidy. Many people think, well, based upon my age, and you've probably heard that, women who are over 35 are at an increased risk for having a baby with Down syndrome. And so therefore, if you were pregnant, the recommendation used to be that over 35, well, you should be having an amniocentesis so that you will know what you're in for, as far as genetics with the baby. Well, now things have changed a little bit. We've got non-invasive prenatal testing. And with that non-invasive testing, somebody has figured out how to, I've got a visual example. Someone has figured out how to take a sample of blood and shake it up in such a way, well, that one doesn't shake anymore. Shake it up in such a way that you can separate out mom's blood from the baby's blood that is circulating through mom's veins, which is really pretty fascinating. And they can they can test that blood to see if it tests positive for any one of a few more common genetic abnormalities, and that's called NIPT, non-invasive prenatal testing. The fact is, though, that PGT testing is not intended for the same thing. So you know that if you're pregnant and you do an amniocentesis, for instance, and an amnio is where we place a needle into the uterus and draw some of the fluid into the syringe. In that fluid are some of the baby's skin cells that have been sloughed off, and so we're able to test those cells for all of the baby's chromosomes. So with PGT, what we're doing is that we are biopsying a portion of the embryo, and that's a portion of the embryo that's going to become the placenta. And really, the goal with doing that is to try to take a large number of embryos and help to separate down the group that has the greatest probability of being able to get you pregnant. So let's say that you have 10 embryos. Well, all right, so we might assume that, depending on your age, maybe that we know that 60% of your embryos or 60% of your eggs, rather, are likely to be normal. Why is that? Why aren't all the eggs normal? Well, the sperm that comes out today was manufactured 3 months ago. But the eggs in the ovaries have been there since you were in utero. So before you were born, the DNA in those eggs has had a chance to become less stable over time. So we know that all the eggs will not be normal. That's an expectation. And that's why IVF just doesn't work every time, because we don't always make normal eggs. Well, so a lot of people think PGT is to say, well, I want to have a normal baby. I said, oh, do you? Do you now? You're one of those people who wants a normal baby. Well, guess what? Pretty much everybody going through IVF would like to have a normal baby. But that's not the intention of the PGT testing. It's not to tell you what, is your baby going to be normal? It has no relationship really to normal pregnancies or to live birth rates. And why is that? Because in most cases, abnormal embryos simply do not implant. Like, you never get a positive pregnancy test. Or in some cases, maybe you do get a positive pregnancy test, but sadly that embryo may end in a miscarriage. That's usually a chromosomal or some kind of metabolic. It's an embryo issue. Well, so PGT testing is not to get you a normal baby, but rather to say, of those 10 embryos, if we think that 6 of them are likely to be normal statistically, that may mean that you have to do 4 transfers before you get to the first one that's normal. And that's a lot of, that's a lot of money. It's a lot of heartache. It's a lot of, that roller coaster ride that I talked about in my Instagram post yesterday. That's a lot of ups and downs waiting to get that positive test. So PGT is beneficial potentially in that scenario to help you select the embryo which is going to have, or the embryos that have the higher probability of getting you pregnant. So that's the scenario I would kind of think about it there. Melissa. Let's see what else we got going on here. At 36, I was told, this comes from Elisine, I was not a candidate for tubal reversal due to 4 abdominal surgeries, 3 C-sections, and a tummy tuck after a lot of weight loss. Is IVF my only option? I just hate to spend all that money with no guarantee. So in that situation, I would agree 100%. You really don't want to have any more abdominal surgery. After all that stuff that you went through and the tummy tuck to kind of try to fix things up, you would rather not try to have a tubal reversal. But yes, IVF is going to likely give you better odds. Now, there's some leeway there depending on kind of what the hormone levels look like. But at 36, generally speaking, the odds of success with IVF are very, very high. So while there are no guarantees in life, my suspicion is that you will spend less for a cycle of IVF than you would spend for getting your tubal reversal done, at least at CNY, than you would spend to get your tubal reversal done, which is going to put you at all kinds of risk from scar tissue and bowel injury and all kinds of other things on the inside. So, yeah, for sure. Chloe Tran asks, for polycystic ovarian syndrome, is mini IVF really the best route to go? Well, mini IVF doesn't, technically speaking, have a medical meaning. So there is not one protocol that is called mini IVF in the IVF world. Now, here at CNY, we do have a protocol that we call our mini dose, and it's pretty standard, but sometimes we even go lower than that. Sometimes it's not even necessary to use a dose that's that high. Women who have polycystic ovarian syndrome have ovaries that will pay very close attention to the medications that we give them in most scenarios. So what does that mean? If we give you, let's say if you are in your 30s, and I give you an age-appropriate dose for someone who is in their mid-30s, but your AMH level is very high, which would go along with polycystic ovarian syndrome, then you are going to become hyperstimulated. So when I say the ovaries, they listen very closely and they pay very careful attention. They know how to respond. So usually what we do in people with PCO is that we lower the dose of stimulation, because what we're trying to do is get quality here, not so much quantity. So yes, mini IVF or low dose stimulation is probably a better bet for women who have polycystic ovarian syndrome. Well, let's see what else we got here. Kelly Presser says, our little Colorado Springs CNY baby is going to be 3 months old this week after a modified natural frozen transfer. Kelly, that is awesome. Love it. Thank you so much for sharing that great news. Layla is here and says, I am 42 years old. My AMH is 1.5. How soon after getting a laparoscopy and hysteroscopy done could we try timed intercourse before doing an embryo transfer? And what medications would you recommend? Well, so I would say if you did a laparoscopy and a diagnostic laparoscopy and a hysteroscopy, that very next month you can be trying to do timed intercourse. And usually with timed intercourse alone, I don't necessarily recommend any other kind of medication. Now, we may do some letrozole for ovulation induction, and that's not a bad idea. Sometimes we'll use low-dose naltrexone, which is a straightforward and easy part of the immune protocol. It increases your endorphin levels, and that has a beneficial effect on pregnancy. So, that seems like a good idea to me. And there's a lot of other sort of little caveats that go in that. But the very next month after your laparoscopy, hysteroscopy, if you're going to do timed intercourse, I think that is great timing. Layla, bring it on. Yes, indeed. Hi, Andre is here. Hello, my friend. Good to hear from you this afternoon. By the way, just a little bit, 34 minutes after the hour. We'll be here for about another half an hour. Fertility with Fink and Friends. My name is Dr. Randy Fink. I am Fink. You are friends. And we're so happy to have you here like every Tuesday afternoon. So the question is, any monitoring centers that you recommend in Southern California, or do you prefer patients to come to you? Well, I don't actually know specifically in Southern California about where I would recommend you go. If you look at the CNY website under Traveling for Care, which is along the top of the main page. You can click that, and then at the bottom of that page, there is a place where you can put in your where you're located, and that will show you a map and give you a list of all the places that we generally recommend for outside monitoring. Now, do I recommend that folks come here to us for their monitoring? I will. That the whole system is designed so that you can do your monitoring outside. So I feel okay with that for sure. However, I will say that I think we do better oftentimes if you can be monitored in a CNY facility, um, because the global team is really managing a very large number of patients, and they do a great job with it. So, very pleased with the job that they do. The number of patients that we monitor in house is lower. So I think you get more individualized care, and there is no running around on our part having to try to track down your results. Because if you've ever done outside monitoring, you may know that sometimes places they don't send us the results, or they process the blood test and we get the results 3-4 days later, or they refuse to read what we know is a follicular study ultrasound and instead just say that you have a cyst or something. There are some pitfalls to the outside monitoring. So if you can do it in-house, I do think you're better off, but everybody doesn't have the ability to come to one of our facilities for 10 days. What some people will do is that you'll do your baseline at home, and then there's not another ultrasound for about 5 days or so. And sometime during that period, right before the next monitoring appointment, you come here, and then you're here for the next 5 days or so, 4 or 5 days. Typically, stimulation portion of the cycle is 9 to 12 days. So some will come here just kind of for the end of it. And I think that hybrid model seems to work very well, with life, because we still have to deal with these life issues of paying the bills and going to work and watering the plants and taking care of the pets, so we know you can't always come. Let's see what we got. B Voyager says, is there a way to have or request my embryo transfer be done without taking any estrogen or low dose estrogen? So the answer to that is yes. That is what is known as a natural cycle or a modified natural cycle. So in a medicated cycle, we are giving you all the hormone that your body needs in order to try to make it work. We give you 6 to 12 days of estrogen. We give you 6.5 days of the progesterone injection, and then you get your transfer. In a natural cycle, your body's making your own estrogen from your own follicle. And as it grows, you make more estrogen, which thickens up the uterine lining. And then when that follicle gets released, and that egg gets released when you ovulate, that is how you start making your own progesterone. So we give you some vaginal progesterone, but you don't need the shot. So yes, the way to do it without having to take estrogen is to let your body be the source of the estrogen, and that's what's known as a natural cycle frozen embryo transfer. Or sometimes we'll add a little ovulation induction, which has a beneficial effect on that uterine lining, and that's what's known as a modified natural cycle. Ellie Mae, nice to see you this afternoon. And Miss Y. Gracie says, just got the dreaded call that my FET failed. Oh, I'm so sorry to hear that. Was on HCG boosters. Does it really make a difference? I'm going to my very last transfer before my journey ends. So, so sorry to hear that. And I hate to think of these things as failures. I think of them as being unsuccessful, but we always learn something. There's always something that we can learn from the cycle and the way your hormones responded, the way your body responded to things. So I sure am sorry to hear that. So HCG boosters are helpful when you have done a natural or a modified natural cycle. In a medicated cycle, HCG boosters they really don't do anything. The reason for that is that doing the booster, the HCG is metabolized really ultimately as progesterone in the body. And as you may know, progesterone is the probably most important hormone for maintaining the pregnancy. Progestational, so pro pregnancy. Progesterone is the most important thing. If you're doing a little HCG booster shot, which is a little sub-Q injection that you do really from the time of transfer um, until you do your if the pregnancy test is positive, you can continue it, even ongoing there. The reason is that you're boosting your own progesterone level. But in a medicated cycle, we are giving you so much progesterone in the form of that progesterone in oil, you don't need any more progesterone. So the HCG booster has not been shown to help. Some people choose to use it because they feel like they are doing something for themselves, and that that must be helping. But in reality, in a medicated cycle, not so much. I'm trying to move this camera around a little bit so that line of light from the sun is not right in my face there, so I don't look like I've got stripes. Let's see if we messed everything up. Well, maybe that's a little bit better, or maybe not. So sorry. Let's see what else we got going on here. Kirsten is here. I always do that, and I apologize. I just had abdominal surgery to remove cancer in my duodenum and a lymph node. Wow. Full open operation above my belly button through an old surgery scar. When can I transfer again? Kirsten, my goodness. Wow. So we're talking about stomach cancer, and in fact, if you've seen some of the articles around, there's the incidence of stomach cancer in younger reproductive age women is on the rise, and nobody is really sure why that is. But I'm so glad they were able to find that for you, and I wonder if you had a Whipple surgery or what you had to do. So I think it's probably at least a couple of months there, Kirsten. So if you had a Whipple operation, which is a very, very big surgery, and sometimes that's what they'll do with that type of cancer, then I'd say it's probably at least on the order of about 3, maybe 4 months, possibly even 6 months before you would want to think about doing a transfer, because there's still an awful lot of inflammation going on in your body. And so we really kind of want that stuff to be turned off. So they would have kind of done a big scar up here because it's a hard area to get to. If it was just they were able to kind of take some stuff out and pluck out a lymph node, and it's pretty minimal, I would say about 2 months is probably reasonable. Although it also depends on how your scar is healing and really on how you're feeling. So I hope and we all would pray that now you are done with treatment, since you had to have the surgery, and that, heaven forbid, hopefully nothing else you really have to do. Kirsten, thank you for sharing that with us here today. Does progestin-only priming for egg retrieval work as good as birth control because of estrogen and progesterone? I'm an IVFing unicorn, asked that question. One of my favorite handles there. I love that. They kind of do some different things. So there are some times when we can't use estrogen in folks, and so we'll do some progestin priming. Priming with progesterone has a better effect of helping to synchronize the growth of the follicles or the eggs that are in your ovary. The estrogen often is able to increase some of the blood flow that's going into the ovary, thus maybe being able to carry some more nutrients to those eggs and improve the egg quality. So they kind of do differing things. Progesterone does to some degree, so I won't say that it is useless for egg quality. It certainly isn't. But I typically think of the progestin priming to try to synchronize the growth of the follicles in the ovary, rather than to try to juice up the ovary from an egg quality standpoint. Um, I am old soul. I am old soul. Okay, what's the role of Provera if you get your cycle regularly? Well, so in IVF, sometimes we will use Provera as an antagonist. So its job is to prevent you from ovulating. So I'm guessing maybe that's what you're asking. In some other antagonist cycles, we use an injectable medication that would be called Cetratide or Ganirelix. Well, it may. I happen to think that Provera works a little bit better. It's way less expensive, and way cheaper, and it's one less shot to get. So it's my preference. The only downside with using Provera as part of a stimulation or as part of an IVF cycle is that you can't do a fresh transfer if you've taken that Provera because it's progesterone and it will mess with your lining. Okay. Maria Honeyloo Scheffler, I believe, says, I'm ready for this IVF to happen. Okay, I get it. Brittany says, does metabolic syndrome affect egg quality without having diagnosable PCOS? And the answer is probably so. Because when you create, so folks with metabolic syndrome, oftentimes, well, what does that mean? Metabolic syndrome is um, typically associated with having excess body weight, with having some higher lipids, potentially higher blood pressure, and sometimes some of the hormonal abnormalities that are associated with polycystic ovarian syndrome. So that would be things like higher levels of androgen, like testosterone. And sometimes things like hair growth and acne. Well, so does that affect egg quality? What happens in that scenario is that your estrogen levels, your basic estrogen levels, are often a little bit higher than they might be in someone who does not have the same kind of problems. And so those eggs are kind of being bathed in estrogen. We want some estrogen. So, like when we talked about just now with priming, we want that estrogen to be going to the ovaries and juicing up the ovaries. So we want enough, but too much is not a good thing either. And typically, metabolic syndrome is associated with being hyperestrogenic. And as a result of that, that can adversely affect egg quality. Now, one of the ways that we often treat that is with metformin. So metformin is medication that's used for folks with diabetes. We use it for people with polycystic ovarian syndrome, and we often use it in women who have both high and low levels of AMH, specifically for egg quality in the IVF world. Hi, Be Positive Girl, like that name. Transfer in Sarasota tomorrow. Good luck with everything. What does CNY charge for outside monitoring? I got to tell you, I don't know the answer to that. And that may surprise you, but, it's one of the things that I say all the time on the phone. I hear Brandis on the phone, and we say, you know what, I'm not, people ask about pricing. I'm not sure. If you look at the CNY website, it tells you all about the pricing. And in your portal, once you're established as a patient, there is a document that's called the financial welcome packet that goes through what really all the specific costs are. Everything is laid out in black and white. And that is, generally speaking, available to the public as well on the CNY website. I challenge you to show me another fertility company that puts their costs, that puts their prices on the website. They don't do it because they want to lure you in, and then when it's too late for you to get out, they hit you with the sticker shock. So pricing is all up front. Take a look at the website. Layla says, when do you decide? Oh, I just skipped Layla. Sorry about that. I'll get back to that. Be Positive Girl. When do you decide on Valium prior to transfer? So we always offer Valium at the time of embryo transfer, but it is not what you think it's for. It's not to help you relax. It's not to keep you from being stressed out. It's not. It is not for as a tranquilizer. Specifically, Valium is a muscle relaxant, and it's a very potent muscle relaxant. Maybe you've known some folks who have injured themselves, particularly certain types of back injuries, and they'll often be put on Valium as an anti muscle spasm agent. It's a muscle relaxant. Now, as an extra added bonus, you get a little nap with it, and it relaxes you, makes you feel like you had a couple glasses of wine. In general, we offer it for all of our embryo transfers unless you are driving yourself. If you're driving yourself, we don't want you having a couple of glasses of wine, as it were. So another good reason to bring somebody with you so that somebody else can drive you home from your embryo transfer. But generally, it's taken beforehand. We've had people who ask, well, can I take the Valium home so then I can take it and then, maybe lay down and take a nap? It really doesn't do anything for you at that point. The goal is to have a little muscle relaxant on board prior to that embryo arriving. Let's see here. What else we got going? I have a video call with the doctor at CNY before actually starting my IVF. Only had my first consult. No, this comes from Rashmi. Good afternoon, by the way. We do not do video calls anymore. At one point, we used to, but believe it or not, people complained about it. And so Dr. Kilt said, well, then we're just not going to do it anymore. People felt like they didn't want to have to look or have to be seen on a video, and so they complained, and so we stopped doing it. So now all of our consultations are really by telephone. You don't have to do a video call. So nope, there will be no video call before starting IVF. Lena's asking, can a body reject a particular baby gender? I have never heard of that happening. I would never say never, but I don't really think that that's a thing. BBBB. I just lost it. Where'd it go? BBBB. BBBB, I lost you. There you are. Even if you're healthy, they can't guarantee. Oh, yep, that's a message going back to Alicine about no guarantees with outcomes. Paige Nichols, what should the next step be after 2 egg retrievals that only ended in 1 day 3-cell embryo between the 2? So that sounds, Paige, like an issue with egg quality. I would work very succinctly on egg quality for you. And how can you do that? Well, there is a list of supplements, comes from the book. It starts with the egg. If you will message me, I'm happy to send that to you. And that's at my Instagram, Randy Fink MD. I will send you that list. I'm actually working on a little ebook right now that will have all that information in it as well to make it easy to come to. So there are up to 10 supplements that are associated specifically with egg quality, and I would be on every single one of them. I would also be on some metformin. Now, metformin, which we talked about a little bit before, is very similar to one supplement that's known as inositol or myo-inositol. Metformin is a prescription. Inositol is a supplement. Metformin is generally covered by insurance, and it's generic, and so it's not expensive. It may cost $5 or $10 for the month supply. Inositol is a supplement, so it probably costs $25 for a month supply because it's a supplement. Metformin is pharmaceutically manufactured, so we know what's in every pill. So I would support the use of metformin over the supplement per se, but I would definitely be on metformin as well. And the other thing to think about is growth hormone. Growth hormone is omnitrope, although there are also some other brands that are available because omnitrope, they've been having some difficult time trying to get from a manufacturing standpoint. I would be pulling out all the stops on egg quality there, Paige. Let's see. Car Hodges says, I am 39 and I'm 39, 6 weeks pregnant through an IUI. Congratulations. Should I continue ovarian bloom? I'm also taking the molecular fertility prenatal and fish oil and low dose aspirin. I would stay on the low dose aspirin. I would stay on the prenatal and I would stay on the fish oil. I don't think you need the ovarian bloom so much anymore. And that really has to do with kind of an egg quality issue. And clearly, IUI hit the spot for you. So, congratulations. Let's see what else we got here. Hello, Lou Photography. Fresh or frozen transfers for someone with endometriosis? Well, I have to tell you, I'm not sure that specifically endometriosis makes the biggest difference there, but things to know: a frozen transfer is always going to have a higher success rate than a fresh transfer. But people absolutely do get pregnant from fresh transfers, and a fresh transfer is included in the price of IVF at CNY. So if you have enough embryos, certainly do a fresh transfer. Now, in your situation there with endometriosis, I would want to know a little more about that endometriosis, because we do know that suppressing that endometriosis for 60 days prior to doing the embryo transfer increases the success rate of the embryo transfer. So that may make me lean a little bit, all those things may make me lean a little bit more towards telling you, unless you have a lot of embryos, that your odds are likely to be higher doing a frozen transfer after suppressing the endometriosis with an oral medication for 60 days. All right, what else we got going on here? We've got about 5 more minutes here. Let's see what we can get. I had a hysteroscopy, laparoscopy. With a hysteroscopy, laparoscopy, does your beta have to be 0? Mine was 8 today. Surgery is supposed to be Friday. That comes from LK She. And I think it really depends on what that situation was. Sometimes people will the beta may just run a little high. It can have to do with their LH levels. But generally speaking, we're going to want a negative beta, although we might just test it again. And if it just really kind of runs the same and there's no possibility that you're pregnant, we might just kind of proceed with it. Looks like mirrorless. If I only have low-grade embryos, would I be allowed to transfer 2 at a time at the Colorado Springs location? So, we will not turn you away. We will not tell you no. There are a set of guidelines we recommend that you follow, which come from the American Society for Reproductive Medicine, that suggest how many embryos you transfer, but people do transfer more than 1 embryo all the time. If you have euploid embryos, we really don't recommend it in most cases, but I'm sure that would work out for you there, Miralus, based on what you are describing. Lachula Escobar. Hi, Dr. Fink. Ooh, I got 3 hearts and 3 lightning bolts. Man, that makes me happy. Oh, yeah. Liz says, I got my transfer on 12/26 and I'm 10 weeks pregnant tomorrow. Hot dog, man, that is fantastic. You got yourself a wonderful little holiday and New Year's present, didn't you? That is great news to hear. Let's see over here on my Instagram. If we're doing a transfer and progesterone tends to be low, can you start earlier on progesterone or go to higher doses? You don't start earlier because the progesterone controls the window of implantation. So it may be that you go a little bit higher dose, but the timing of the progesterone, if it's in a medicated cycle, is generally going to be 120 hours plus or minus 3. So we don't start it earlier, but sure, we might increase the dose a little bit. Do ask about that when you're getting set up for it, for sure. Beccatini says, I just got over COVID last week. Glad you got over. And I want to start a cycle next month. I have a low AMH. It's 0.97 and wondering if I should go ahead or should I wait for 3 months? And I think the answer there is, you're going to do what you feel is right and what is best, because over time, the longer we wait, the greater the risk that we're going to continue to lose eggs. But I do believe there's been evidence, and we have seen the evidence here, in our own clinic and in my own friends, that 3 months after COVID really does seem to make a difference in egg quality. A special hi to Jody Hoffman, especially since now we're about to sign off and be done. Jody decides to come on at the end of the program. Appreciate that. as always. Let's see. What would you suggest? 90 Frump 90. Would you suggest removing a pedunculated fibroid before starting IVF? No, not necessarily. A pedunculated fibroid is not likely to have really any impact on the rest of the uterus, certainly not on the uterine cavity because of where it's located there. Pedunculated means it's sort of sticking off the uterus. Oh, wait, look. We can use my friendly example here. A pedunculated fibroid sits on the outside, sitting on top, or let's say the back, it's sitting out here, it's sticking off, sometimes even with a little stalk. And that usually does not have any impact on pregnancy or ability to conceive. Well, folks, I think we are about out of time for this Tuesday. What a bunch of great questions we got here today. And I'm sorry I couldn't get to all of them, but a very special shout out to each and every one of you. Thank you so much for being here. I know you got other places that you could be, and I really appreciate that you stick around. Like I always say, we want to lead forward with hope, most of all with hope, but with kindness and love, and hope that tomorrow brings new and exciting things for all of our lives. This fertility business, it's not your book. It's not your novel. This is only a chapter. And God knows we are here together to rewrite that chapter. God bless everybody. Happy Valentine's Day. Thanks so much for being here, and I'll see you next week. Good night.